One, I think because we have very limited time, so without wasting any time, so we'll go on to our next IC, that is step-by-step vitrectomy. And there's a small change in the schedule of talks that we have. Dr. Manisha Agarwal has to leave for the airport, so she'll be giving her talk before the other speakers. Her topic is taming the vitreous, handling the core, periphery, and the posterior vitreous detachment. So this is going to be a course which, on an intermediate basis, we'll talk about the basics and some innovative techniques of doing vitrectomy and the things that they don't teach you in a fellowship. Uh, Dr. Manisha, please.
So good morning everyone, and thank you Dr. Sangeet for making me a part of this wonderful IC. I'll be teaching the basics of how to go about doing a vitrectomy. So can I have my video please?
Periphery and posterior vitreous detachment.
Starting se kariyega.
Firstly, it is important to clear the media, taming the vitreous, handling the core, periphery and posterior vitreous detachment. Firstly, it is important to clear the media haze before we actually plunge into doing a vitrectomy. This is a case where the posterior vitreous was already detached, so a core vitrectomy was done using a moderate high suction and a high cut rate. Posterior retina, as you see, becomes more and more jumpy as the posterior hyaloid is separated out. To avoid the retina from inadvertently coming into the cutter port and stabilizing it, a bubble of perfluorocarbon liquid is injected at the posterior port. Subsequently, the peripheral vitrectomy is carried out using a low suction and a high cut rate, which is also known as the shaving. One can also use scleral indentation, which gives a better view of the peripheral vitreous, and basic session can be easily performed. What we need to keep in mind is the least
have some audio
of the vitreous
volume should
while performing the peripheral vitrectomy, especially to avoid dialysis. Scleral indentation is performed to identify any peripheral retinal breaks. Presenting the various techniques to induce the posterior hyaloid detachment, that is, catch the hidden ghost. PVD induction with active suction of the cutter. Intravitreal triamcinolone is injected, which helps to stain the posterior hyaloid face. The excess of it is removed with the help of the cutter. We can now identify the attachment of the posterior hyaloid face to the retina, which is gradually lifted up by using active suction of the vitrectomy cutter. A beautiful V-string is appreciated, and the posterior vitreous detachment is taken to the periphery, and the vitrectomy is completed. When we have posterior vitreous stuck to the fovea, we may sometimes require to use the active suction of the cutter to take it tangentially over the surface of the retina and gradually induce the posterior vitreous detachment all around the fovea. The fovea may have the strongest attachment of the vitreous, which is induced the last. We can also induce the posterior vitreous detachment with the help of a spatula. Here a retinal spatula is used to create a plane between the posterior hyaloid face and the retina. This refused to come out with the help of the active suction of the cutter, and thus a passive technique is used where a spatula is gradually lifting up the posterior hyaloid face. Now gradually the posterior hyaloid face is lifted up, inducing the posterior vitreous detachment. We can also induce the posterior vitreous detachment with the help of forceps. So here first the cutter was used to induce the PVD. However, it was found to be very strongly adherent to the retinal surface. Therefore, a forceps was used. End gripping forceps is used to hold the edge of the posterior hyaloid face, and it is peeled like ILM peeling over the macular area. We can also do a bimanual induction of the posterior vitreous detachment. We find there is a chandelier light is fixed. The posterior hyaloid is very badly stuck to a detached retina. No plane could be appreciated on the posterior pole, therefore the posterior vitreous is gradually detached from the periphery using the forceps and the retinal spatula. And we find that gradually the entire posterior hyaloid face is detached from the retinal surface using a bimanual technique. There is some amount of bleeding, which also shows how tightly the posterior hyaloid face was adherent to the retinal surface and to the retinal blood vessels. Once the posterior hyaloid face is detached, the vitrectomy cutter is then used to induce it further and to complete the vitrectomy. The cutter is used to induce the posterior vitreous detachment towards the periphery. And we find that as the posterior vitreous is detached, the retina is seen to be more mobile. The vitrectomy is then completed. Perfluorocarbon liquid is injected to stabilize the posterior bone. And more vitrectomy is done in the periphery. The PVD is very different in a diabetic patient. The posterior hyaloid is often plastered to the posterior pole with attachments very strong to the retina at points of fibrovascular proliferation. Here a 26 gauge needle is being used to nick the posterior hyaloid and a small opening is made in it. Gradually this opening is expanded to separate the posterior hyaloid. Visco is injected in it to get a plane of dissection. Forceps is used to lift up the posterior hyaloid. And then a cutter is used to separate the posterior hyaloid from the underlying attachments of the fibrovascular proliferation. If we pull the posterior hyaloid, like in a case of RD, we will land up having multiple retinal breaks. To summarize, the success of any VR surgery depends on the induction of PVD. Be patient and individualize each patient. It may require assessment and application of various techniques to induce the PVD.
Thank you, Dr. Manisha, for covering all the
The
types
vitreous
of PVD
handling
induction
the core,
techniques.
periphery and posterior
Just
vitreous detachment.
before you leave, just a small question. What do you say when
Firstly, it is
and when you will
important to
not
clear the
use
media haze
triamcinolone
before we
while
actually
inducing
plunge
PVD?
into doing a vitrectomy.
I think as we are starting to do a vitrectomy, it's mandatory that we use a triamcinolone, because many a times I've seen when my fellows start operating, they feel that the PVD has been induced, but when you go in and you inject an IVT, and they find that the entire vitreous was there. So I really don't know where would be those situations when you would not like to use, but I would personally suggest that it's best done. Many a time there is a surprise, especially in high myopic patients, where you can have a schisis and you can have multiple layers of the vitreous which are beautifully appreciated with an IVT.
Thank you.
Thank you so much.
Thank you and have a safe flight.
Thank you.
So just a word of caution before we move on to our next topic is that triamcinolone does not stain the vitreous. It just absorbs on the vitreous. So anything, you need a rough surface for the thing to absorb on it. So if there is a smooth PVD or smooth posterior hyaloid, even triamcinolone will not be able to stain it. So if you suspect that you are not still getting the proper plane, just explore despite your triamcinolone not staining the hyaloid. So just a word of caution.
Yeah,
Yes.
like in a diabetic patient, I think the whole posterior hyaloid is so badly stuck at the back. So even if you inject an IVT, I really don't think it's going to be of much help until or unless you've created a plane of your dissection and then you get the posterior hyaloid out.
Yeah.
Thank you so much.
What do you do in pediatric cases, like ROP cases, when we are operating, we are not able to induce the PVD there? What do you do in that kind of cases?
So I personally don't do ROP surgeries. Maybe Dr. Sangeet can answer that
So
better.
many of the times if you're doing a ROP surgery in very initial stage, we don't reach that stage where we need to induce an ROP. So in most of the cases, stage 4, stage 4B, you don't need to do a complete dissection of the vitreous itself. So in those cases, the less you do is best. In stage 5, definitely you have to separate the membrane from the underlying retina that is there, and in those cases, it's not very difficult doing that.
Thank you, sir.
Yeah. Now I invite Dr. Parth Rana for his talk on machine setup, instrumentation, walkthrough, and ports, the Vitrectomy Command Center. And I think the first, the thing that is well done, well begun, is almost half done. So if you do the ports correctly, I feel that is one of the most important steps when the complications do happen.
Very true, sir. First of all, good morning. Thank you so much, Sangeet sir, for including me in this IC. I would like to ask first question, like how many of you are already using a vitrectomy machine? Rest, like have you evaluated your machine, like how it works, and have you compared the machine with something, some other machines? So here I am going to tell you like what the components of vitrectomy machines are and how it should work and what are the benefits and what are the disbenefits of the components of this vitrectomy machine. So first we need systems standardization that dictates the surgical success. For training, if we see like what machines we are using in our parent institutes, they are that same thing we should reproduce in our OR. Otherwise, what happens like if you have used a constellation in your training institute and you have started using a basic machine in your basic Indian machine in your OR, then the standardization is not there. You won't understand what is happening and you will start having some complications in that. Other thing is safety threshold. IOP management should be proper. Because in vitrectomy machine, like when we are removing the whole vitreous, it's not like a cataract surgery where you can just change the bottle height and everything will be there. Because anterior chamber is very small chamber, and you can control it by just bottle height. But if you are removing the whole vitreous, and if you want to control it, it's very hard if your machine don't have the IOP controls. Then the complication mitigation is standardized setting should be there. Primary defense against the all iatrogenic traction complication is your machine. Because if your machine is sucking too much vitreous and you are not able to cut it properly, then you are going to have a iatrogenic hole there. So your machine, you should know first and then you should use it. So this is the basic anatomy of modern vitrectomy console. So first we see it's the interface. This interface is going to have all the parameters on that, and it is programmable for, like your foot pedal will be programmable from there. Then the main engine is there. It is having the centralized fluidic system that that is regulating dual pump architecture and vacuum parameters. Then the network is there. It is high-speed cutter connections and multi-channel light source will be there in that. Then the access point will be there from where all valve and non-valve trocar systems are connected to the globe. Here are the main pumps which are used in latest all the vitrectomy machines. So if you see, first one is the peristaltic base, and another one is venturi based. Peristaltic is simple thing. It's a milking kind of system. So from one side it is pushing, and then it's pushing from other side, and it's kind of milking, and it's pushing the fluidics there. And venturi system is a vacuum-based system. So basically, vacuum is generated in the cassette, and it's sucking all the fluid. So basically, peristaltic, it goes slowly. It builds vacuum slowly. But venturi, it builds vacuum very fast. So if you are a newcomer, peristaltic is a very good machine for you. Venturi for advanced system, it's if you are an advanced, if you are a pro surgeon, then venturi is best. If we see the flow rates, the direct machine impact of pump selection on instantaneous flow rates and holding power is there. And IOP control nowadays all the machines are having, and it is kind of mandatory. Here is the main thing, like nowadays if you are seeing like 10,000 cut rate and 20,000 cut rate, and now even 30,000 cut rate is available. So we have to understand the dynamic of this. So what is happening here, like we have to see how long the port is open in the face, and how much time the port is closed. So what is happening here, when the port is open, it is sucking the vitreous inside. When the port gets closed, the guillotine of the cutter goes down and it cuts the vitreous. So if you are near the retina, you need the higher cut rate, because there you want to chew the vitreous in very small pieces. If you are getting the large pieces there near the retina, then you are high chances that you are going to suck the retina inside and you are going to cut the retina. So near the retina and shave phase, the cut rate should be higher. And if you are going for the core vitrectomy, if you are just removing the anterior vitreous or just core vitreous, the cut rate can be slower. That's why if you see all the phaco machines, they have low cut rates. They have 1,500 or 5,000 cut rate cutters are there. But for retina surgeons, for vitrectomy machines, the cut rates are always higher. And we have the cutters. Previously we used to have 20 gauge, now we have 23, 25 and 27. The most used cutter right now is 25 gauge, because it is having the dual function. The port is smaller and the cutter is not that fragile. 27 gauge cutter is very fragile. We are going to make a very small hole, but the cutter is very fragile, so it creates some issue. Then dual cycle physics is there. So in that, how it cuts, we need to see for that. Surgeon-defined presets can be set in that. So if you have multiple surgeons at your place, you can just define your cut rates and define your mechanism, and machine can do like that. Foot pedal logic we have to see, because there are multiple type of foot pedals available in the market. If you see for the Alcon foot pedals, they are straight foot pedals. If you are pressing first, it is going to increase the suction, and if you press for second time, then it is going to start the cutting, and the cutting is not linear. Suction is linear first. So in first stage, slowly it will build up the suction. But in second stage, if you start, the cutter will be having whatever preset you have done, 7,500, 10,000, 20 or 30, it will start cutting at that rate only. But if we see in some other like Gauter machines, they have linear suction as well as linear cutter. So if you are pressing straight, then it will start the suction, and if you are pressing on side, it will start the cutting, and on side it will be linear. It won't be direct on whatever preset it is. So this is the sterile workflow you should have in your system. First, you should have the boot check, and machine should be powered on, system diagnostic and loading surgeon-specific preset should be checked first. Aseptic preparation should be started, and during that time, you should have the sterile field ready. You should connect your cutters, your cassette and everything. You should start the machine, prime the machine. Once the machine is started, then only block should be started. Otherwise, we have faced this kind of things that when block is already given and machine is not starting, the machine is not tuning, machine is not priming, then it's a big blunder. What will you explain to the patient? So first thing, like once the priming is done, then only the block should start. Then this is the basic geometry of standard 3-port architecture. We need to have a 3-port, one for light pipe, one for vitrector, and one for infusion cannula. Infusion cannula is always on temporal side because we have a big nose in between where we can't manipulate more. So the infusion cannula should be on temporal side, and depending on your primary hand, if you are a righty, then cutter should be go from right, and if you are lefty, the cutter should go from the left side. So the port should be made around 3.5 to 4 millimeter away from the limbus according to the phakic or aphakic patients. And if we see for optimizing endo-illumination, there are multiple ways. Like we can use the light pipe also, we can use chandelier also. If we are doing a bimanual surgery, then we need the chandelier illumination there. And chandelier illumination port should be at that point where you need the maximum illumination, where you want to do the maximum dissection. That port, that side, you should put the chandelier, because so many times what happens if chandelier is very far from there, sometimes which main point you want to do the dissection, you are not able to do because of the not proper lighting there. And these are the advanced port strategies where you want to do the bimanual dissection. You should see properly from which angle you want to do dissection. According to that, the port should be there. And it shouldn't be on opposite side. You won't be able to do the surgery like this. So when you are doing the surgery, and 3 and 9 is the best position, but there the vortex veins are there. So you need to be little bit above that. And that is the best position to do all the surgeries. And nowadays there are 2 different kind of viewing system. It's not part of this, so I'm not going with this. And for expanding the anatomical limits, we need to see for the higher gauges, as I told before. For higher gauge, there are some benefits and there are some problems with that. So main benefit, you are going to make very small incision. So if you are just going with 27 gauge, you are not, you won't be needing any sutures after putting the oil. But what happens in 27 gauge, you won't be able to reuse it more, because these cutters are costly and we are not going to charge that much to the all patients in our routine OR. So what happens here, if you are using 27 gauge, if you are using for 1, 2 or maximum 3 cases, the whatever return is there from that, it will be kind of difficult. So basically 25 gauge, what is used nowadays, it's kind of good from both the worlds. 23 gauge is very sturdy, 27 gauge is very soft according to that, and 25 gauge is in between something, where if you are not taking sutures post surgery, that also can work. Fluid compensation also can work nicely in that, because fluid is coming from the gauge, what you are using. So if you are using 27 gauge, the port for that, it's very small. So sometimes if you are taking higher suction in that, sometimes globe can collapse. But 25 gauge, it's good for both the sides. And the robotic assistant, that is also going to come in future. But right now it's kind of far away. But in US, it's already started. Dr. Uday Devgan's video is also there on YouTube and Insta. So I won't go in much there beyond this. Thank you.
Thanks a lot, Parth. I think one of the commonest mistake that at least I made when I started doing vitrectomy was that I didn't study my machine before going ahead with the vitrectomy. And I think most of us be making those mistakes. Consider your machine as your life partner. So know maximum what you want to know before you go ahead with your life partner. So that's the same with the machine. Another thing is don't not nowadays the persons will come, sir, this is 10,000 cuts, this is 5,000 cuts, this is 20,000 cuts. So don't go into that cutter war. Like faster cut rate does not mean a faster surgery. So in fact the faster the cut rate, the slower the surgery will be. So don't go into that cutter war thinking that okay, I have 30,000 cuts, I'll be doing it in faster mode. So it is not like that. The definitely faster cut rate has some advantage that makes the surgery safer, but on the same hand, you have to decrease your suction in those cutters to a lower level, which again negates the advantage that the faster cutter is giving you. So don't go. And the last thing about the infusion port, that he said, is the most important port that you are making. Everything, your surgery is going to depend a lot on that. So once you make your infusion port, always check whether the infusion port is inside the vitreous cavity before starting the infusion. So that is the point you make maximum complications. So I think that is what I'd like to add. Any questions for Dr. Parth?
So basically what you told, I agree to that, and most of the time I tell not kind of life partner, but I tell it's kind of my hand and leg there. For my machines, I love cars, so for car also I always, whenever I explain to anyone, I tell them this is my body part. If I don't understand like what is the capability of my body part, I won't be able to excel in what I am doing. So that's why we have to know the machine first, and then we should start using it. Because the machine, when you are able to use it at 100%, your results will be best.
Yes. Thank you, Dr. Parth.
Thank you.
So we move on to our next speaker. The topic is the art of the peel, mastering the ERM and ILM peeling techniques. Dr. Neeraj Sanduja, who is a prolific vitreoretinal surgeon and runs his own practice in Gurgaon, will be speaking to us on this on mastering the epiretinal membrane and internal limiting membrane peeling techniques. Over to you, Neeraj.
Thank you, Sangeet. And thanks for giving me this opportunity. So my topic for presentation is the first one.
Can we have the audio? Some audio is, I think.
Come. Okay, thank you. So Sangeet has given me this topic of mastering epiretinal membrane and ILM peeling techniques. Next. So whenever we are doing a macular membrane surgery, we should aim for a good, not perfect peeling, and we should avoid any excessive manipulation of the peripheral epiretinal membrane or ILM remnants. And complete ILM is mostly recommended, but if you're not able to do, then don't go after that. So I'll be showing some videos how we do this membrane peeling in different scenarios. So as pointed out earlier, you need to stain the vitreous, or maybe the vitreous is being absorbed by this transflone. Then you put brilliant blue dye, and you can see this, there is a thick membrane over the macula. I'm trying to peel this membrane off, but you can see how adherent this membrane is. So I have to be very careful while going over the fovea. I should not de-roof the fovea while doing this membrane peeling. And you can see I'm trying to go in a very circumferential manner, because I just want the membrane should be peeled off or around the fovea without causing much of traction. And you have to go very gently, and here we can get a good peel over the fovea. You can see this membrane is coming out beautifully, but you can see the membrane is still adherent at some places. So you have to just assess it and then go gently. Otherwise, you can land up into iatrogenic retinal break formation also. And still some membranes are there. I'm trying to peel it off because you don't want again recurrence, and again you restain. You can see still some membranes are left behind. So it is always better to peel as much possible without damaging the retina. So we are identifying the membranes, seeing whichever is coming gently, and this is not coming, you need to leave it. Then again, another remnant is there just close to the fovea, needs to be removed, otherwise it can lead to reproliferation of membrane. So you can see triamcinolone staining, brilliant blue staining, and repeated staining may help you in taking care of the patient and removing this membrane. This is a preoperative and post-operative picture, and you can see how beautifully the fovea is getting its contour back. Another case, triamcinolone staining and PVD was induction was done. Now you can see another thick membrane over the fovea, over the macula, peeling this membrane with the help of hand gripping forceps. And you can see most of the membrane is being peeled off, but still it is quite sticky. Again trying to catch a grip with the hand gripping forces, still not coming. So not very comfortable. Still going again, trying to peel it off. Still not helping me with this because it is breaking, so fragile this membrane is. Now I'm going with the diamond dusted spatula, and you can see how beautifully this is helping me to get the cleavage plane. And this membrane is so fragile, so thin, it is coming with the diamond dusted spatula. I'm just trying to peel it off as much possible I can do with the help of this spatula. Now going with the hand gripping forceps, again seeing whether I can peel it off. And you can see this membrane was not covering only macula, but all around, away from the macula also. And most of the membrane is now coming out. Now going with the vitrectomy cutter, and whatever was left behind with PVD induction, suction of the cutter, I'm just trying to take all the membranes out. And still you can see some membrane was there. I had stained with brilliant blue and taken this membrane out, because unless you take this out, there is high chances of reproliferation of epiretinal membrane, especially if you're dealing with epiretinal membrane. ILM gives a scaffold again for the reproliferation. So this is how our surgery is over. This is a preoperative and postoperative picture. Now another interesting case of this adherent membrane. This case, you can see after brilliant blue staining, I'm trying to peel off this membrane. So sticky this membrane is. Simply not coming. And inadvertently, if you peel it, you grasp, regrasp, you're likely to damage the retina also. Sometimes you can grasp the retina. And you can see now, yes, membrane is coming out. Again, as I said, I go in a very circumferential manner so that I should not lead to any deroofing of the fovea. And then I realized this membrane is stuck to the fovea, tightly adherent. Just simply not able to get away. I thought maybe let me peel it 360 degree, assess the situation, and then just pull it. Again holding, grasping, regrasping, being very patient. I didn't want to make the patient worse than what he was before surgery. And you can see how thick this membrane is. Another remnants of membrane are coming. So thick they are. Going in a circumferential manner, grasping, regrasping, just assessing whether I should not pull on the retina and cause any iatrogenic retinal break. When we started the surgery, we never knew like it is going to be so adherent. Now you can see the stump is there. I thought I'll just trim the membrane with the help of a vitrectomy cutter. So whatever I could do safely, I did that. And again, I'm trying to reassess how adherent this membrane, because see, if I pull this membrane, this will just tear the fovea. So I went with intraocular scissors, just lift it up gently again and again. And see how beautifully this membrane has come out of the fovea. So this is a preoperative and postoperative picture. So in macular membrane peel, there are variable factors. Every case is different. So you have to see how adherent this membrane is to the fovea, surgical experience and preference for surgical technique, and diamond dusted spatula, triamcinolone, brilliant blue staining is an integral part of the peeling to minimize complications. Thank you.
Thank you, Neeraj. I think we are learning more from the next one rather than the audio so much. So anything special you do for this ERM and ILM in a detached retina?
In, see, in that you can put PFCL over the posterior pole, and then you can and you stain with brilliant blue, and then you stain the membrane in the PFCL bubble itself, and then you start peeling this membrane. It gives a tamponade to peel it off
Yeah.
in a better way.
So we have to take care in peeling the membranes in a detached retina. It's a little bit difficult than what the peeling in an attached retina. So one thing, as Dr. Neeraj had said, is like put a bubble of PFCL and attach the at least the posterior pole, and then you do peeling under that. Another thing is like when you are peeling in a detached retina, always try to peel from the disc to move away from the disc. So that will give you a lot of traction from the disc, and you'll be able to peel the membranes easier. Another thing, what he mentioned in his talk also was staining is important, but a negative stain is also very important. So if you're not getting a stain, is another thing that indicates that there is something, some membrane which you're not seeing, and then you have to explore for that membrane. And I think when you do a staining, sometimes you'll get a patchy stain. That means there is a ERM and which is irregular. And the best is to start your ERM peeling from the edge of that stain. So where you get that stain, you will be able to get the membrane from that. That is the indicates the edge of the membrane.
And very important thing, if you see something shining over the macula,
Yes.
and you are not getting any stain, it means the posterior hyaloid face is still stuck over there.
Yes.
Something is there. That is also a very important feature.
So any questions for Dr. Neeraj? Can we have some mic over there for? Can we have a mic?
Especially on the surface of the pupil, pupillary margin and remaining iris also. Most of the cases I keep the fluid in a lower setting.
In adherent, you can use diamond dusted spatula or finesse loop also to start your peel in case you are not able to get the edge of the membrane. Otherwise, you can pinch, repinch, you will get. Otherwise, to make it much safer, even I am also very comfortable going with the diamond dusted spatula, especially in internal limiting membrane peeling. And once you get that, the things become very easy, and it is less traumatic, I would say. My preference is to remove the silicone oil because it gives you assessment how contracted retina is, and once the membrane is free, the retina becomes very mobile and you are 100% sure all the membranes have been removed completely. Under the silicone oil, you don't get that feeling. So you can peel off membrane, but sometimes the things become murky also. You taking out the membrane, and then the silicone oil may become a little murky. If thick membranes are there, maybe you can go and just peel it off, but plenty of membranes and a lot of contraction in the retina, better to remove the oil and then take it off.
What is your say on that, sir?
Better to remove. Oh, okay.
So I generally do both. So I start peeling under the oil. That I think just gives me a traction over the retina. As instead of using PFCL, I'm using oil. And then when I am sure that everything is removed from the posterior pole, then I remove the oil. Then I search for more membranes. There are always very hidden membranes which are there. So you remove the oil, complete the membrane removal, and then again put the oil. I prefer to do stepwise approach.
Sir, any tips to avoid hydrogenic break when it's very adherent ARM? Because sometimes it creates large flap.
No, as I pointed out my videos also, you have to leave those membranes where you see the adherence. And the last video showed how adherent that membrane was to the center of the fovea. Had I not been cautious, it would have led to de-roofing of the fovea. So each case has to be assessed. And as sir said, like, you need to get the edge of the membrane to start your peeling. Start peeling, go gently without over traction, and go in different directions. You don't have to go in a one direction, like just take it off. Then you are likely to land up into more complications. But if you're going very gently, circumferentially, tangentially, the things will become safe. It may take little more time, 2 minutes, 5 minutes more, but the things are going to be really, really less painful for you.
If the
Thank you. So let's continue the course. Like my topic is reattaching the retina and the retinectomies. So reattaching the retina, we generally follow this fluid air exchange, a fluid exchange, or a fluid PFCL exchange. So fluid air exchange, we have to do either a posterior drainage retinotomy or we try to drain through the existing break. So these are the two options that are available. And this is the diathermy used to make a drainage retinotomy posteriorly, and then the drainage is done with the vitrectomy cutter through this. This opens up the little fibers that are still remain attached to the retinotomy side. Then you can continue with your back flush needle, the fluid air exchange. So this is generally how we do a normal fluid air exchange. In the end, you have to do a laser around the retinotomy site and then close the case. And this is sorry. This is how we make drain through the pre-existing break. You tilt the patient's head to make the break the most dependent part. Then try to dry the retina as much as possible. So you see in this patient, I have tilted the head of the patient. Try to make the break. Then you tilt the head back to its normal position so that the residual SRF slips down to the posterior pole. Then you can laser around the breaks, and then you can give a tamponade and ask the patient to lie supine for some time so that the residual fluid still which is there gets absorbed, and then you can position the patient accordingly. So you can use the anterior breaks as a drainage site rather than creating a posterior drainage retinotomy in many of these patients. And where is the ideal retinotomy lives, where the gravity helps, vessels rest, and the retina feels strong. So it should be ideally in line with the pre-existing breaks, should be easily accessible with your dominant hand, should be mid-peripheral away from macula, arcades, and major vessels and vortex veins. Avoid the areas of lattices or thin retina and atrophy, and it should be accessible if there are subretinal bands. It should be accessible to subretinal bands, otherwise you'll be creating another retinotomy to remove those subretinal bands. So coming to the fluid exchange, you can do it as internal, but like in thick turbid fluid or long-standing TRDs or exudative RDs, or you can do it external when you want to avoid unwanted retinal breaks. So this is one video I'm showing doing a fluid exchange in this thick fluid. You see the fluid is very viscous. If you try to do a fluid air exchange directly in these eyes, you won't be able to flatten the retina completely. So better you do a fluid exchange before you dry the retina completely. Then you can switch on to your fluid air exchange later on, and you will get a proper attachment rather than going with the direct. So if you are suspecting a chronic retinal detachment, you expect that there should be some viscous fluid lying, and then you can proceed with the. And this is a external drainage. This is a technique I follow. I use a IV catheter, 26 gauge IV catheter. I enter the subretinal space. I remove the metallic stellate, and I let the plastic tubing remain in the subretinal space. Connect it to your extrusion pump, and then you can. You see the fluid can be. This is in patients where you don't want any retinal breaks to happen before you are proceeding with your surgery. Sometimes it's very helpful when there is no space to enter. You can do this drainage. And this was a diabetic patient. I didn't want to create any retinal breaks. I did this technique. So sometimes you can do it from the external route also. So fluid PFCL exchange generally we prefer in large breaks like giant retinal tears or where retinectomies are done. So what you do is I generally create a PFCL, a bubble to flatten the retina. And in this is a patient of a giant retinal tear, and the fluid moves as the posterior retina attaches. The fluid moves anteriorly and it gets drained from the giant retinal tear itself. So this is then you do a direct PFCL oil exchange or whatever way you prefer, and this is the way I do a direct PFCL silicone oil exchange. So these are the three basic methods of reattaching the retina: the fluid air exchange, the fluid exchange, and the fluid PFCL exchange. So now some pearls for effective retinectomies. So the basic retinectomy indications are PVR, especially the interior ones, the necrotizing retinitis, retinal incarcerations, anterior flap of GRT you have to excise. In secondarily recurrent RDs with PVR, extensive subretinal gliosis, subretinal blood, oil or PFCL. And retinectomy, one thing you have to remember, is not a substitute for hyaloid dissection and a proper membrane removal. You have to do a proper membrane removal even if you are planning a retinectomy in that case, whether the membranes are epiretinal or subretinal. And then you include areas of residual pre-retinal membranes that cannot be peeled. So this is a small video showing to remove this circumferential traction. This is I'm showing that despite I knew that I had to do a retinectomy, in this I just try to remove as much of traction beforehand as possible, because then these things shorten your retinectomies. If you don't remove the membranes, you will create a larger retinectomies rather than a shorter retinectomies. Then you manage the fixed folds which are posteriorly, and then you create a relaxing retinectomy. In this way, you will get a shorter retinectomies. Retinectomies can be done under BSS, it can be done under air, or it can be done with PFCL or BSS. This gives you best of both the worlds. Usually use PFCL to flatten posterior pole. It stabilizes the retina, then prevents postoperative posterior retinal folds, and it determines the tautness of the retina and helps in identifying the residual traction. And make sure that all the anterior posterior and tangential traction is removed before injecting PFCL. So you see all the membranes have been removed, the posterior membranes have been removed, then put a bubble of PFCL. Even the ILM peeling is done, all the subretinal bands are removed, and then only you put in PFCL to control the. So if you have to create a retinectomy before you are going to inject PFCL, just make sure that you do not complete the whole retinectomy at first. Just make a small retinectomy and then you remove the bands and then inject PFCL. And you always get a razor sharp edge. You create a well-defined line using endodiathermy. It creates a stencil which can be followed by vitrectomy cutter and also prevents bleeding. And planned edge of retinectomy should be free of membrane traction or rolling, as I said. So small video, you create a diathermy edge with the diathermy, and then you can proceed with your retinectomies. So generally I do a segmental retinectomy. I let the retina attached for some places, at least 3 places, and then remove most of the, then I fill in with PFCL, and then I proceed with the complete 360-degree retinectomy if I want that. So you see, I'm following the edge of these retinectomies. It prevents the bleeding, and it also creates your edges very sharp. So you have to do an adequate retinectomy. Don't shy away. If you have planned to do a retinectomy, then you don't shy away that I have to limit it to 1 clock hour or 2 clock hours. You have to take care of whole the transaction. And you be direct with the tamponade. You do a direct PFCL silicone oil exchange. It's easier to visualize the PFCL silicone oil interface and makes the exchange easier. And there is a decreased risk of retinal slippage if you do a PFCL air and then air silicone oil. It will give you an extra step also, and it's easier. So direct PFCL tamponade can also be done in some cases, but you see I have burnt my fingers, but I don't advise it. That you can see there's a lot of complications with PFCL tamponade as well. So this is a retinal necrosis following a PFCL tamponade and the recurrent GRT under the PFCLs. As I said, don't undercut, take care of whole of the traction, and you will have very gratifying results. This is 1 week post-op. I've taken care of whole of the traction. I planned that I'm going to remove this retina. And in cases of giant retinal tear, always clean up the anterior flap. It serves no visual or structural function and is just a scaffold for reproliferation. It can roll over the ciliary body, resulting in hypertony, and may contribute to anterior loop traction. So always remove the anterior flap. And if there's a giant retina, again you'll cryo or laser the lateral halls of the retinectomy, because again your fluid may slip through them and cause a detachment anterior to your laser marks. So that again may lead to problems later on. I think that last video, this is retinectomy under air. This is least commonly done due to sometimes you have subretinal air, reduced visualization in meiosis. But it is the most accurate titration of the endpoint. So if the air is subretinal, do a retinectomy till you get all of the bubble outside. So this gives you, now this is maximum that I have to do. We don't have to extend further, and it will give you the proper titration of the that whole of traction is relieved. So this is a small video just to show there was a subretinal air in this patient, and done. I'm doing endothermy to mark the edge. Now I'm doing the retinectomy, and as I keep on doing it, the retina keeps on flattening. The air keeps on coming into the vitreous cavity, and it gives me an exact endpoint where I stopped retinectomy and then completed my fluid air exchange safely. And you see, there was still some residual subretinal air. I extended the retinectomy further till I got whole of the air out from the subretinal space. And you see the retina is flattening side by side. You don't need a PFCL bubble also to support the retina behind. And just do laser, and I'm sorry for the quality of the video. I think because under the air you always get some compromise with the quality of the video. So, but you do laser and you just exchange your air with silicone oil. You no need for PFCL also. This is 1 week post-op. So just to end, I'll say that performing a retinectomy, although conceptually simple, it looks simple, but it requires attention to detail at each step to help ensure the best possible outcome of it. Thank you. Normal RD, I generally don't do it because then it adds to more of your inflammation, more of your proliferation, more epiretinal membrane formation post-operatively.
And by chance,
I just do a limited barrage around the breaks where I've seen. Only in cases where you are not sure whether there is a missed break or not, I don't generally do it.
And if you do 360 barrage, then how many rows you do it?
Generally 3 to 4 rows in a normal patient, but in a giant retinal tear, I generally go 6 to 8 rows. In the primary surgery?
In the primary surgery?
In the primary surgery, if there is no earlier PVR, I don't do a belt buckle. So nowadays, what Dr. Yusuke Oshima's latest paper has come, he has said that even a retinectomy or a buckle does not cause it. There was no significant difference if you do it, even in the secondary surgeries.
Like in PVR cases, you don't put any belt buckle. Resurgeries also.
In resurgeries, I tend to do a buckle if I am not planning a retinectomy.
Okay.
The pouting edges of an existing break, sir. How will you handle it?
Pardon, sir?
The break is already there.
Yes.
But the edges are so much PVR and they are contracted and
yes.
pouting.
So I try to get off as much membrane as possible, but if it is not coming out, I'll just like to trim that edge of the break to make it a fresh whole kind of thing, and then I'll proceed with the... I now invite Dr. Dhanashri for her talk on the surgeon safety net, the complications that happen during routine vitrectomy procedures.
So, good morning, Dr. Sangeet, for this invitation. So, I'm going to talk to you about the surgeon safety net, complications and rescue maneuvers. No financial disclosures. So, you see the cartoon here. The cartoon, the surgeon is saying that if you do run into complications, Jerry will just Google it. So, it is a comic, but it's not actually the done thing, because complications are an integral part of surgery. So, if you are doing surgery, you be assured that you will have complications. The only way to have no complications is not to do surgery at all. And Dr. Atul Gawande, the famous surgeon and author, He says in his book that complications, a surgeon's notes on imperfect science, he says that why complications occur, because we think medicine as a perfect science, but actually it's not a perfect science, and the knowledge is changing every day. And we rely, especially in vitreoretinal surgery, we rely a lot on technology and machines and all that, which can fail at any time, any moment. And of course the humans are also fallible, so complications may occur, and it is prudent to be prepared and tackle the complications rather than say that we will not have any complications at all. So how to prevent complications? Now most important is pre-operative evaluation. So do not go into the OR without being fully prepared and without knowing the patient and the case that you are going to operate. So under the pre-operative evaluation, a thorough evaluation is required, including the visual acuity, the anterior segment evaluation, that is the corneal clarity, how is whether there is rubeosis or angle, what is the state of the pupil, whether it is dilating or not, how is the lens, whether it is clear or whether you need to combine it with cataract surgery. Then fundus examination is of paramount importance. The media clarity, are you able to see the retina? Then what is the severity of the fibrovascular proliferation? What is the extent of the RD? What is the extent of the PVR? How is the disc and macula? If there is no visual media clarity, then an ultrasound or a CT scan, MRI, all that imaging has to be done. And most important is the status of the fellow eye also, because the fellow eye, how is the fellow eye will dictate how you should manage this eye also. And along with that, the general medical condition. Then well begun is half done. Make sure that you have all the required instruments ready. Make sure that the instruments are in good working order, and you also have some backup in case the instruments fail. And also make sure that you have good visualization system, because that is very important, and without good visualization it is very difficult to perform surgery. And a very honest self-assessment is also required. So after seeing the case, you must assess yourself whether you have the skills to tackle it. It would be prudent to not touch the case if you feel little unconfident, not so confident of handling, and better to refer it to some higher center. So that is otherwise you will land up in a mess. So better to have an honest assessment. Also, it is important that you stick to the trodden path. The people before you have burnt their fingers, and then they have given you the guidelines. So it is good to stick to the guidelines and follow the whatever guidelines are available, and also do surgery when it is absolutely necessary, not because somebody has advised or because the patient wants. You should assess very honestly whether this patient is going to benefit by surgery or not. If he is going to benefit, then only perform the surgery, and even then expect the unexpected. Especially vitreoretinal surgery is very that way unpredictable, and you can land up with problems even without when they are not expected. So there are many number of complications that can occur in VR surgery, and it would be impossible to cover them all. So I am just going to cover a few common complications that occur. So here this the image is showing one skydiver which has dived without a parachute, of course, but there is a safety net. The parachute is there, which will open later. So this is just to illustrate the risk that he is taking. So the first complication is the infusion cannula in subretinal space, and this can occur sometimes in a situation where there is trauma. So this trauma patient, where you can see the cornea, there is almost no iris, but you see the infusion cannula is not visible, it is under the retina. So before starting infusion, must make sure that the cannula is visible. Now the advantage is that you can shift the cannula to other sclerotomy and then make clear this space for this sclerotomy. Here the sclerotomy is quite anterior. Even then the cannula was gone subretinally because the retina is pulled anteriorly. So one must take care of that. Now this situation here, you can see here the entire 180 degree inferiorly there is a corneal limbal wound, and there is a vitreous incarceration in the wound, and obviously you will have retina also incarcerated. So it is prudent not to go in that area at all. So we have given all the three sclerotomies in the superior quadrant. So the infusion is placed at 12 o'clock, and then you have the superionasal and the superiotemporal sclerotomy to do the vitrectomy as you normally do. And for sure this patient had retinal incarceration in 180 degree. So had you given the infusion in the inferior quadrant, it would have gone subretinally. And sometimes these are extreme situations where the retina is completely in the pupillary plane and there is no way you can put an infusion cannula. So here there is a AC maintainer which is being used in the beginning to put the fluid, and then there is one limbal incision is given, and we are trying to remove this membranes from the retina in an order to see whether the retina can go down. So these situations are rare, but you can tackle them if they arise. Okay. So next is the intraoperative choroidal detachment. So this video actually doesn't show the exact moment whether the choroidals occur. This is after that, but you will get the point. So here I am checking the infusion cannula. So when you see that during surgery you will suddenly see the choroidals occurring, you must immediately stop and make sure that the infusion cannula is still in the vitreous cavity. Sometimes during manipulation, especially if you are doing peripheral indentation and all, the cannula can move and can go in a suprachoroidal space, and you will suddenly see choroidals occurring. So in this patient, that is what happened. So we looked at, now you can see there are some choroidal mounts are there. You can see this. So choroidal mounts are there. So if you recognize them and stop immediately, the choroidal mounts will not progress. Otherwise, you may have 360-degree large choroidals, which will make further surgery very difficult. So the idea is to recognize them in time and then take care. So next is intraoperative bleeding. So this is a very troublesome complication, I would say, mainly in diabetic retinopathies. You have large proliferative membranes. Whenever you try and cut them, the intraoperative bleeding can occur. Sometimes there is very excessive and intensive bleeding, which will even prevent your surgery. And it is of course good to give preoperative anti-VEGF to reduce bleeding. But for bleeding, this blood which gets it gets immediately clotted and stuck to the retina, and it is sometimes very difficult to peel this blood. And while peeling the blood, you might create iatrogenic breaks. So the good idea is to cauterize these bleeders as soon as you notice them. And you can also do other maneuvers like raise the intraocular pressure and wait for 1 or 2 minutes to see whether the bleeders they can stop or not. Okay. Of course, a preoperative assessment of the coagulation profile and all also has to be done. And sometimes these end-stage kidney patients with end-stage kidney disease are also very prone to all this. There is also another idea is to use tranexamic acid. So this video is from Dr. Jayanta Guha. Maybe I'll just go to the end. So tranexamic acid is very commonly used in situations like cesarean, gynecological surgeries, oculoplasty surgeries. It is a antifibrinolytic and it prevents bleeding. So what you do when you have so much of bleeding, this is the tranexamic acid, the dilution is done, and then it is injected after fluid air exchange. Some amount of tranexamic acid is injected into the vitreous cavity, and it is left there for about a minute or so in order to stop the bleeding. And then you can remove the tranexamic acid, remove the air, and go ahead with your surgery as routine. It does give good effect, and the bleeding can be controlled. It can also be given intravenously or orally half an hour or 1 hour before the surgery in consultation with your anesthesiologist. Silicone oil in the AC is again very common complication, most often because the surgeon has already left and the fellow is doing the silicone oil injection and they encounter this problem, and many times the fellow doesn't know what to do. So this is here you can see as soon as that trying to form the AC, although the intraocular lens is there and ideally there should be no, but sometimes through zonular weakness the oil will come into the AC. And what happens with the air or with fluid, the oil does not go back and you have to inject viscoelastic. So viscoelastic should be injected in such a way behind the oil bubble so that it can be tried. You have to actually push the air bubble towards this limbal paracentesis. So you can you can inject from one side and depress the paracentesis from the other side so as to allow the silicone oil bubble to come out. But you can see more and more oil will keep coming as you depress the AC. So the idea is to keep the AC full and not depress it. So now here we have achieved the oil has gone back. But it is very important to make sure that on table this is done, because if you leave the oil in the AC, it will remain there, it will not go back ever, and then you may have to do a second surgery. So better to tackle it immediately at that time. Third is air under the retina. Sangeet already mentioned that. So here this is a case of recurrent RD and then I am doing the membrane removal. And what I thought, after adequate membrane removal, I thought I will do the fluid air exchange. And as I was doing fluid air exchange through the peripheral break, you can see that it was going on well. But then suddenly the air went under the retina. You can see the peripheral retina is now the air has gone under the retina. So air under the retina indicates that there is some residual traction, and this needs to be taken care, because if you leave it like that, you will of course the surgery will fail. So ideal would be to remove this air, put the fluid back again, assess the retina, remove all the membranes, and then do retinectomy. But sometimes we do shortcuts like this. Sangeet also mentioned. So in experienced cases, you can do this retinectomy under air. Broken scissors is one very funny complication which in India we see because we are reusing the instruments, and sometimes these 25 gauge and all those instruments are so delicate and they will break in the middle of the surgery. So here one scissors blade has broken and fallen down. You can see the fibrovascular membranes and all are still there, and now this is an additional foreign body removal has to be done. So I'm holding it with the forceps and removing it. Also the patient is phakic, so it is very difficult sometimes because there is a possibility that you can either touch the lens or you can endanger the retina. So it needs to be done very carefully. Preferably use good scissors which will not break. Okay. Right. So life is 10% of what happens to you and 90% of how you react to it. So any complication can be tackled. It is more important that you stay calm and composed and take care of the complication rather than panicking. And of course, one essential of risk management: don't do anything wrong today and don't do anything wrong tomorrow, and then repeat. So if you are interested in knowing about complications, I invite you to attend this Retina Summit conference in Shankar Netralaya. It will be held from July 9 to 11, and this will mainly focus on complications of retina surgery. So it would be quite educational, I hope. Thank you so much for your kind attention.
Thank you, Dr. Dhanashree. I think you rightly mentioned the most important thing is not to lose your patience at that time. So just wait for sometimes if something has happened, just wait, just think of it. If you think that you are going to able to manage it, proceed. Otherwise, stop, close the case, maybe read about it or send to a person who is able to manage that complication. I think that is a very nice thing you told in your lecture, that patience is the key in managing these complications. And always be ready, like the last complication she showed was that the instrument broke down. This instrument malfunction is another thing, because we are reusing our instruments, not like the West. We are reusing our instruments day in and day out, and these instruments malfunctions do happen with us commonly, and so we have to check them before we enter the eye.
Ma'am, tranexamic acid you showed, like what is the concentration you use it?
So actually I have never used tranexamic acid, so that's why I had to borrow the video from Dr. Jayant Guha. But the concentration, what he informed me, that they dilute that whatever commercially available injection is diluted with some 0.5 ml of saline, and then it is just dropped into the vitreous cavity, and then it is removed after some time. So I'm not sure about the exact concentration, maybe we'll have to look up the literature. But since it is only intravitreal and then it is removed, probably the concentration is not probably that dangerous, even if you are using high concentration.
Yes, we are using oral tranexamic acid in most of our PVR and PDR cases. But
so what is the dose that you are using?
The oral whatever routine concentration is available for gynecology cases, the same we are using it for a long period we are using, and it gives good results. But intravitreal I saw the first time, and it's really good thing, like during surgery we can use it, and if it's really useful then it's nice.
Yeah, because some of the anesthetists, they have concern of using this tranexamic acid because it can predispose to hypotension, bleeding later on. So you will have to, in our setup, we'll have to take the anesthetist permission to do something like that. Whereas intravitreal is under our control, we can give it any time.
True, ma'am. And ma'am, after the PDR surgery, when we are removing all the membranes, everything is settled, and we are seeing, like in a month or two, we are seeing some bad membranes, which is like pulling whole retina, and the whole retina is kind of necrosed after that. So what to do to prevent something like that?
So reproliferation is a very, very common in diabetic retinopathy, and sometimes this the polyps which come back again, they are so kind of dangerous and florid and so much gross. Sometimes you will think that the original surgeon has not removed the polyp at all, but if the original surgeon is you only, then you have done some good job. But even then you will have reproliferation because of the bleeding and because of that whatever inflammatory reaction which is there, and also if you have put silicone oil, then all that gets kind of plastered to the retina, and you will end up with reproliferation. It's very difficult to deal with reproliferation, and very often actually you may end up doing retinectomy, but you have to use many times you have to do it like a second case, and then you have to do the dissection again, like how you would dissect the proliferative membranes. And in my experience, it is quite tough to remove these membranes, and as I said, many times you end up with iatrogenic breaks or retinectomies. So that is why it would be good to do the good job in the first place and try and remove as much blood as possible.
Do you use any immunomodulator, like immunosuppressive in your BSS or
No,
IV fluids, then you are anticipating more of PVR formation.
Yeah, no, we are not using, but I think in Madurai they are using routinely. They are doing methotrexate for PVR. But in methotrexate and all, you have to give repeated injections every 2 weeks, intravitreal injections. I am not very sure about the infusion cannula, infusion fluid. I don't know. We'll have to look up at the toxicity. Maybe Sangeet.
I am not using. I think this is the end of the session. The people are already waiting, so we can discuss
we
it
can discuss
outside.
outside, yeah.
outside. Yeah.